Yeah, yeah.
Yes, we can start, sir.
Yeah. You have to open my video. I cannot start my video. Hello?
Yes, sir.
No, then I cannot open my video. The start video has been closed, no? You have to open it. Now it's okay. Now
Yes,
it's
sir.
okay.
Yes, sir. The video is on and the room is open now, sir.
Yeah, we'll wait for 2 more minutes to let the people join, then we'll start. Okay.
Yes, sir.
Okay, right. Mohan sir, good morning.
Good morning, sir. Good morning.
Sir, കൈ പൊക്കി കടിച്ചേക്കുന്നല്ലോ എന്തെങ്കിലും ഉണ്ടോ?
ഒന്നുമില്ല സാർ, വെറുതെ ഒന്ന് ഗുഡ് മോർണിംഗ് പറയാന്ന് വിചാരിച്ചിട്ട്.
ഓക്കെ ഓക്കെ ഓക്കെ, റൈറ്റ് റൈറ്റ്.
എന്തൊക്കെയുണ്ട് സാറിന്റെ കാര്യങ്ങൾ?
ഒന്നുമില്ല, എങ്ങനെ പോകുന്നു? We'll start in 2 minutes time. Just 1 more minute, we'll start. Okay. People are joining only.
Bathroom jail.
Okay, we can start now. Okay, Venkatesh, shall we start? Shall we start, Venkatesh? Mohan sir, am I audible to you?
Yes, sir. Please
Yeah,
start.
we can start now. Start. Okay, good morning, everyone. Just like this is, I think, it's the 40th session on this challenging case series. So as usual, I'll start with the short case first. Is my screen visible? Is screen visible now?
Yes, sir. Screen is visible.
Okay.
Go to the full screen.
Okay, thank you, Dr. Buch. Now, now, this is a very short case. This is only one involuntary movement. The duration is only for 1 day. You can do this involuntary movement now. Oh. Also got tremulous movement in forward and backward. I'm asking you to keep that forward. It was inside. Okay. Now, think about this. Something at rhythmic myoclonus or motor stereotyping. I'll go to the next, show the next video also. Next part of the video. How to coax the attention to an അച്ഛൻ്റെ മൂക്കത്തോടെ മൂക്കത്തോടെ ഇനി ഇന്നോട് ഇനി ഒന്നുകൂടെ തൊടെ എൻ്റെ വിരലത്തോടെ ഇനി വിരലത്തോടെ ഇവിടെ തൊടെ തൊട്ടെ തൊട്ടെ ഇവിടെ തൊട്ടെ ഈ കണ്ണ് തൊട്ടെ ഈ കൈ ഒന്ന് തൊട്ടെ ഈ കൈ പൊക്കി തൊട്ടെ പിടിച്ചോ അച്ഛൻ ഒന്ന് മുറുക്കി പിടിക്കേ ഈ കൈ മുറുക്കി പിടിക്കേ മുറുക്കിക്കോ അച്ഛൻ മനസ്സിലായില്ലേ അച്ഛൻ കൊണ്ട് നോക്ക് മനസ്സിലായോ ഞാൻ പറയുന്നത് മനസ്സിലായോ അത് ഇങ്ങനെ പിടിക്കണം ഇങ്ങനെ മുഷ്ടി പിന്നെടുത്ത് അത് പിടിച്ചേ ഇത് പിടിച്ചേ എൻ്റെ കൈ പിടിച്ചേ പിടിച്ചോ Okay, so what do you think the likely possibility here?
Asterixis.
Yeah, perfect. But what about the tongue movement and the jaw movement?
Tongue is more like chorea, and jaw movement, oromandibular dyskinesia.
Okay, what condition would you keep in mind at the back of the mind?
Uremia, sir. Uremia.
Yeah, perfectly right. So this kind of that what you observed initially was something like choric movement, or rhythmic myoclonus, more like rhythmic myoclonus and the tongue protruding jerky movement, because it is repetitive. Chorea is non-repetitive, it's more like a repetitive movement. And I've seen many kind of these funny myoclonic movements occurring in renal failure. So this patient was this EEG done such on diffuse slowing, and he is a known case of CKD on dialysis. In fact, he came for the dialysis on the day he developed this myoclonus, and next day everything disappeared. So just to show you that various types of jerky movements, involuntary movement can occur in CKD. Now I'll go to the real case. Yeah. Please, anyone want to ask this question?
Polymyoclonus
Polymyoclonus is we can mimic the negative. It's actually called a negative myoclonus. See, Asterixis is a negative myoclonus. It cannot sustain the movement, the hands goes down. The other is real myoclonus. The occurring in the tongue and the jaw deviation is something like a real myoclonus. Okay. Now, this is a 40-year-old man. He is history of sudden onset of headache and vomiting. Is 2 days back. Associated with blurring of vision, which improved with closure of either eye. It also combines of tinnitus of right ear and numbness of the right half of the face. So he had presented with sudden onset of headache and vomiting, followed by blurring of vision, which improved with closure of either eye, most likely due to the diplopia, tinnitus of the right ear, and numbness of the right half of the face. This is the position of the head in this patient. His head is tilted to the left side. On examination, he had head tilt to the left side. At right superior oblique palsy, that's why he had head tilt to the left side. Decreased pain on the right half of the face, but the corneal reflex was normal on both sides. He had mild gait ataxia, no neck stiffness, but Kernig sign was positive. So this is the finding. So where do you think is the possible site of lesion in this patient? It's also another short case. Long case is yet to come.
The lesion must be in pons, but it could be in the cisternal part of the right side of pons, or so the right superior oblique palsy should be on the left nuclear, and the right half of face pain is the trigeminal nucleus on the right side.
Correct. But left side to be extra axial, no? Because intra-axial, yeah, right. That's one possibility. So let us see the any other one. Anyone else would like to make a comment or suggestion? Okay, so let us see the probability. The lesion is extra-axial or intra-axial. That's the first question. Extra-axial is the apex of the petrous bone, as Dr. Bitch was telling, or with the weight coming down to the sapiangular region. We can explain the right vithna, right superior oblique weakness, as well as tinnitus on the right side, with extension to the right CPI. But is there anything odd in this patient? The problem is he's got ataxia on walking towards the right side. That becomes odd. if it is extra-axial, how to explain the ataxia? And why is that corneal reflex is normal on the right with sensation affected on the right face? These are the 2 points which are against the extra-axial lesion here. Now, can be intra-axial then, like a right pontine lesion. This can explain the right fifth nerve, ataxia to the right side, or ataxia, right eighth nerve, possibly extending to the cochlear nucleus on the right side. But what is odd for a right intra-axial pontine lesion? How to explain the right fourth nerve pulse? If you want to think of an extension to the right lower midbrain to implicate the right cochlear nucleus or the outbrain nerve, the pulsed muscle affected should have been on the left side. Here is on the same side as the right side as the lesion. So how to explain everything together? So there is points against intra-axial, points against extra-axial. So,
Sir, the fourth
yeah.
nerve comes from the opposite side and exit.
Correct, yeah. So if the lesion is on the right half of the pons, how to explain the right superior oblique pulse?
If it is after exit, then but in that case we have to bring an
After
extraction.
it means it becomes subarachnoid.
Yeah, separate.
It is dorsally in the superior medullary velum. The crosses immediately exits.
Yes.
So because of the,
Just before crossing.
Pardon?
Just before the crossing.
Just before the crossing, it should be contralateral.
so because of the acute onset of headache,
Yeah.
can you think of SAH because of aneurysm?
Yeah, that's an etiology part of it. What we are interested in the site of lesion. Site
So
of
subarachnoid space can explain, no, sir? If in the same
Yeah.
side, fourth nerve.
Right, that can explain. Only point is that I can't explain why the corneal reflex is normal on that side and there is right side and ataxia. Or ataxia in this patient.
Why can't like so intra-axial going into extra-axial? Like, it's a angioma bleed with extension onto the subarachnoid space.
No, that's a very rare possibility. They can bleed into the ventricle. Bleeding outside this thing is hardly ever, that's hardly ever occurs. Can bleed into the ventricle. Moreover, that's again you have to implicate the outer space, the fourth nerve. I mean, it has come out and implicate the fourth nerve going onto the apex from the pons to the apex of the penis terminal bone. Okay, so let us see what you need now. You want CT scan? This is a CT scan. Pons is normal.
So, but there is a pre-pondent bleed, sir.
No. That's only artifact. That's an artifact CT.
Sir, I have one doubt, sir.
Yeah, please.
As for an intra-axial lesion, the fourth nerve should be affected. So superior oblique is supplied by the left fourth nerve nucleus and the right trigeminal. So that is one factor which can go against an intra-axial lesion.
Exactly, perfectly right. That's what I initially said.
So
You can point out spontaneous explain everything except for the right superior oblique pulse. That should have been, if it was affected on that right, extending to the right side of the midbrain, it should have been on the left side. Here it is on the right side. That's against intra-axial. But there are points against extra-axial. Okay. Can you think of any other intra-axial location where you can explain everything in this patient? Okay, I'll come to that. So MRI pons normal. What else you need? So this is a midbrain cut. What you see is a hemorrhage in the left superior colliculus, inferior collicular region, lower midbrain dorsally present. Can you make out the hemorrhage here, the dorsal aspect here?
Yes, sir.
Yeah. What was the clue to say that lesion is not in the fifth nerve brainstem outside the fifth, outside the brainstem? The corneal reflex is
Ataxia.
corneal reflex is normal. Now let us see how we can explain everything to this patient. This is the MRI showing again a lesion hypertension in the left inferior colliculus region. Now, how to explain the right-sided tinnitus if the decreased sensation on the right side? The pain loss can be it can be due to affection of the spinal nucleus or its tract on the same side, or ascending endothalamic tract on the opposite side. As you all know, the pain fibers go to the spinal nucleus, descend along the descending tract, enter the spinal nucleus, and cross to the opposite side and ascend to the endothalamic tract. This is the thing I have shown again. The tract closely accompanies the spinal nucleus. It ends in the nucleus at various levels and cross at various levels to form the endothalamic tract. This is, I have drawn this diagram. This is the one posteriorly situated, represented most downward in the spinal nucleus, middle in the middle, and the perioral region the uppermost part, and then cross to the opposite side at various levels from the ascending endothalamic tract. Now, if you find a lesion on one side of the face, numbness on one side of the face, lesion can be the spinal nucleus here on the left side or on the right side in the ascending endothalamic tract. But if the lesion happens to be in the endothalamic tract, corneal reflex will be spared. On the other hand, the lesion is in the spinal nucleus or descending tract, corneal reflex will be affected. So suppose the patient loss of pain on one side of the face like this. How to know whether the lesion is ipsilateral, descending tract, or in the ascending endothalamic tract? If it is in descending tract, corneal reflex will be lost at the same point I said, whereas corneal reflex will not be affected, the lesion is in the endothalamic tract. Since our patient has affection of ascending endothalamic tract, corneal reflex is spared. Now, how to explain the tinnitus on the opposite side? This is called tactile deafness and tinnitus. You can have deafness due to a tactile lesion called tactile deafness, an inferior follicular lesion. But it is partial and that is contralateral to the site of affection. This is due to the lesion of the inferior collicular which receives the lateral lemniscus fibers carrying auditory fibers. Here, curiously, here the pure tones are spared, mimicking pure word deafness. This is a tactile deafness on the literature. So, summarizing the location one by one to explain our patient. Fourth nerve is there situated here. It is affected in the nucleus or the exiting fibers are affected before crossing on the left side. That will explain the right superior oblique palsy. The lesion here in the ascending endothalamic tract, the dorsal part of the spinothalamic tract, lateral spinothalamic tract, where it can produce contralateral loss of pain on the lateral face. And the tectum is affected to produce the tactile deafness. And this is site of lesion which can explain the present finding in this patient. And that is borne out by the CT scan also. The location of the CT scan also. So any questions?
What about the ataxia?
Ataxia due to the involvement, this lesion might have involved when the crossing the dendrothalamic fiber, supraspinal peduncle here. This supraspinal peduncle, the supraspinal peduncle going like this and crossing here. Then might have encroached and involved to the cerebellar fibers.
This case was presented some few months back, so the same.
Yeah, it was presented a few months back. I just wanted to know how many of you remember that.
I just joined, so I couldn't.
It was presented a few months back. Exactly. But still nobody could answer. Now I'll go to the real long case now. Complaint started. This is not a note. This case I have not presented before. Complaint started 2 years back as a transient clumsiness of the right lower limb while walking, which spontaneously improved over 2 weeks. This 2 years back. 1 year later, patient had a similar problem lasting for again 1 to 2 weeks. 5 months back, patient was noticed to have some awkwardness in the gait, in that his left thigh goes outward while getting up from sitting position, with foreign dragging of the left foot. This is all from the history. But the parents gives very clear history in this patient. He was also noticed to have some drooping on the left shoulder. Patient was investigated an MRI was done. It was put on steroids and his left lower limb problem improved to normalcy over a week's time. He remained asymptomatic till 1 month back when he noticed almost similar problem in the right lower limb and got admitted now. So I reiterate the history once again. First episode 2 years back, right clumsiness of the right lower limb which improved spontaneously. Then 1 year later, patient similar problem lasting for 1 to 2 weeks. 5 months back, awkwardness in the left thigh. This time it's the left side. Thigh goes outwards while getting up sitting position to getting probably an adductor weakness or something else, and plus dragging of the left foot. He was also noticed to have some drooping of the left shoulder. It's put on steroid and the problem improved. Now come with the almost similar problem in the right lower limb for the last 1 month and I think 1 month back and then admitted now. This is the video of the patient. Very cooperative child. Ocular movements were normal. There is no gaze restriction or anything. There was no caring. The rest of the time was all normal. Tone is normal in the upper limb. Power ourselves in all the muscles are normal.
ആർക്കാ ബലം നോക്കണമേ എനിക്കാണോ മോനാണോ എന്ന് അറിയണം പിടിച്ചു പിടി 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 ആ പിടിക്കാം നീ ഇങ്ങനെ പിടിച്ച് പിടിച്ചു 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 പിടിക്കാം നോർത്തി പിടിക്കുക ഇത് പിടിച്ചോ അത് വിട്ടാൽ മതി ഇനി എൻ്റെ വിരലിൽ ഇങ്ങോട്ട് ചെയ്യാൻ ഈ കൈ ഇങ്ങനെ അടിക്കാൻ നോക്കട്ടെ ഈ കൈ അഭിനവനല്ലേ പറഞ്ഞ പേര് മറന്നുപോയി പിടിച്ചോണം പിടിച്ചോ 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 നിർത്തിക്ക് പിടിച്ചോ അല്ല പിടി മതി വിട്ടോ വിട്ടോ ഇത് പൊക്കിക്കേ പിടിച്ച് നിർത്തിക്കോ അത് വിട്ടോ വരട്ടെ അങ്ങനല്ലേ മോനെ എൻ്റെ കൈ ഇങ്ങനെ ചവിട്ടണം പോരാ ആ ഇപ്പം ശരി ഇപ്പം ശരി അതൊരു ചവിട്ടിക്ക് ചവിട്ടി മാറ്റി നിങ്ങൾ മാറ്റിക്കോ മാറ്റി 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 വിടേ
power is normal, PANDAS is normal.
തണ്ടവരിൽ പൊക്കി പിടിക്കും മോനെ മുള്ളോട്ട് പിടിച്ച ഒന്നുകൂടെ വിടക്കെ ചവിട്ടിക്ക് കൈയ്യിൽ ചവിട്ട് വെള്ളം തുമ്പത്ത് തൊടണം
There is no incoordination at all.
തുമ്പായില്ല തുമ്പത്ത് തന്നെ തൊടണം തണ്ടവരിൽ തൊടണം അതേപോലെ ഈ കാര്യം കൊണ്ട് ചെയ്ത് താഴെ കൊണ്ടുപോകാൻ
From the right
താഴെ മുട്ടിക്ക് ഇനി ചെയ്യും
proper. Comes on the right.
ഈ താഴെ മുട്ടിക്ക് ഇനി ചെയ്ത്
But he was able to hit better.
ശരി നീ വെളുത്ത കാര്യം കൊണ്ട് ചെയ്ത്
But right side was. At the same time, on lifting up the lower limb, there was no attach.
ശരി മതി മതി ചുമ്മാ ഇരുന്നാൽ മതി കേട്ടോ മതി
The reflexes were all normal.
ഒന്നുമില്ല മതി
Now reflex.
ഇത് കണ്ടത് ഇവിടെ നട്ട് ആ കഴിഞ്ഞു ഓൺ ചെയ്തായിരുന്നോ
Apex normally executed.
അതിന് മുറുക്കി ഒന്ന് രണ്ട് മുറുക്കി പിടിച്ചേ.
That's also normal.
മതി വിട്ടോ.
And eject now.
മുറുക്കി പിടിക്കുമ്പോനെ
And
കഴിഞ്ഞു. ഇക്ലി ആവത്തില്ല കേട്ടോ.
I think for the interest of time, it's an extension number I will skip because they are all normal. Very careful. Not come to the gate and
അതേ
able to stand with I
നീ കണ്ണടക്കണം. ഞാൻ കണ്ണടക്കുന്നത്
homework study.
ഞാൻ കണ്ണ് തുറന്നിട്ടില്ല. ഞാൻ കണ്ണ് തുറക്കുമ്പോൾ പറയും കേട്ടോ.
The gate, the right one. Back the right road. I took a more clumsy up.
സ്പീഡ് വേണം.
The more clumsy.
അതേ മാറി
Can stand on
ഉപ്പിട്ട് പൊക്കി ഇങ്ങനെ നിൽക്കും. എന്നോ ഒറ്റക്കാലിൽ നിന്ന് ഒരു കാര്യം
some keep tagging on one side.
ഈ മറ്റേ കാര്യം നിൽക്കും. മറ്റേ കാലിൽ
Standing on right side, better. Back. And then that's what was okay. Now forwards with the right load. The right leveling goes out to there.
നേരെ പൊക്ക്.
Because if it can, right is not being smoothly up.
ഈ മറ്റേ കാലിൽ
Goes out.
താത്തെ
Remember the left side. So the left side comes straight like
താത്തെ
forward.
ഇനി പൊക്കെടുത്ത കാല്
The right side, it goes out and comes.
താത്തെ ഇനി പൊക്കിക്കാൻ വലത് കാല്
That's it. Normal.
വിട്ട് ഇങ്ങനെ പൊക്കിക്ക് ചേർത്ത് പോയി.
I wanted to check for the weakness detector once again. It was normal.
ഒന്നൊരു കാലകത്തി പിടിച്ച്
Conditions of
ശരി മന എഴുന്നേറ്റു.
we can get a starting. There is nothing.
10 പ്രാവശ്യം ചെയ്താൽ
We can get a
5 പ്രാവശ്യം ചെയ്താൽ ക്ഷീണിച്ചാ മതി 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 മതി.
I'll show the gate once again because that's the thing which is good for the diagnosis. Act on one's right side. And the X goes into, Y goes into adduction.
സ്പീഡ് വേണം. ഇനി സ്പീഡ് നടന്ന് കുറച്ചുകൂടെ
And then office box.
ഓക്കെ.
Not flexible like.
നടന്നു
Okay. Summarizing, KLS normal, motor power normal, except some clumsiness of the left upper limb during fast movement, and some fatigability in the right hip adduction. Right hip goes into abduction while walking. TTR normal, sensation normal, gait dragging of the right leg, more of a heel drag. Tenenberg test is hip sagging on the right side. Okay, that means when standing on the right side, the hip sags on the opposite side. That's what I meant. Because when you stand on the right side, lift up the left leg, the hip sags. When he stands on the left foot, there is no sagging, indicating that clumsiness or weakness on the right side of the hip. So what do you think is the possible diagnosis in this patient? What is his walking difficulty due to? And what could be the etiology?
Fatigability, so sir, binaural junction.
Yeah, it could be a minorization because some fatigability is there, but we couldn't prove it. And so fatigability could get up squatting position any number of.
Drooping of the shoulders, sir.
That was there in the history, but I couldn't.
that is.
In the previous admission, they noticed some drooping. Literally from the history.
Myoclonus junction local problem, sir. I don't.
Manual junction is a possibility. Okay.
Local problem.
Any other possibility?
There is no weakness, no, sir.
No, that does not appear to be weakness. In fact,
Primary hip joint problem or something.
that's the thing you have to always keep on this. Normal power and concentration, especially inside, always shows a degree. That's a good talk. Anything else? Okay.
Can you call this gait circumduction?
I don't know which, because true circumduction is not there. The hip goes into abduction while walking, and it's not present all the time at times. And continue to walk, it becomes more clumsy and awkward. I will show you one more time the gait later on. It become more clumsy later on. And he tends to keep the knee extended while walking. He does not flex it. I'll show that, I think, for that clarification. Just show the gait once again, the second part of the video. That's on the right side. But walking fast, the knee extended. I'll show you the next one. Now you see that better walking fast. See that, and there is appearance something like a something like on walking fast. It is now it becomes obvious on walking fast. And unlike spasticity, it is not the forefoot; it is a heel which becomes touching the ground.
Sir, while he was extending the knee in sitting posture,
pardon?
Sir, that while he is extending the knee at sitting posture,
yeah, exactly.
It is that leg is coming outwards and coming straight.
Exactly, you are perfectly right.
That is also tells that he has a knee extensor weakness also, or some knee joint pathology.
Correct. When you're extending the knee, it's not going straight away extend. It goes like outward and then extensor.
It tells some knee extensor weakness or some knee joint pathology, sir.
But it's not an extensive because you can extend normally. What is normal? Normally also.
Congenital dislocation keeps up.
That's a possibility. But he had no pain at any time. And the things, you pick back the history, it happened 2 years back. He improved spontaneously. Then again recurred. The third time here on the left side, he was imaged and then put on treatment with steroid that they are very clear about it and improved. Now admitted 1 month back. So a hip joint disease, why should occur? Shift from one side to another and improve with steroid. That's the problem.
One more thing is got a abduction, short abduction.
Pardon?
Short doping also, that also improved.
That previously, that also improved.
Any history of headache?
No headache, no headache. Okay, let us see this patient is intensively investigated outside before came. So this lactate was normal, kinase was borderline, calcium normal. Then I'll go to the LFT normal, parallel panel normal, TSH normal. So he was imaged, lumbar spine was done, which is MRI lumbar spine normal. This is axial cut. They thought some problem in the, what do you call it, the element paralysis of the postural muscle. That's why he keep going like that. That's investigated. Cervical spine was also normal. Now, what else you need now?
Brain?
Brain will come
Hip
to that.
is normal, sir. Hip.
That will come to that. NCS was done. This investigation, so that investigation. NCS also normal.
RNS, sir?
RNS അവർ ചെയ്തില്ല, ഞാൻ ചെയ്തില്ല.
Sir, MRI hip, sir.
So they were repeating the MRI once again in the same hospital 2 months later, and again is normal. That is normal. So they did a CSF. CSF showed 10 cells, protein 18, glucose 76. Now what else you need? You have to join this problem.
No, no.
Hip joint
Unlike
is normal. He also 19 space will be tally. Improvement and shifting from one side to another is.
Sir, usually transient synovitis at the hip can occur, which it might be painful and it could also be painless also. That's it.
2 years.
10 cells in the CSF, that it's significant. So,
When the Mohan wanted MRI brain, is normal. What is the diagnosis?
What was potassium?
Normal.
Calcium, sir.
Normal. It was normal. The first thing was calcium was normal.
No, sorry, no.
sir, what is the reason, sir? CSF pleurositis, sir?
CSF showed 10 cells.
Any reason?
If protein was normal, lymphocytic.
But reason, sir, I never sir.
Reason നിങ്ങൾ കണ്ടുപിടിക്കണം.
Sir, autoimmune, sir, എല്ലാത്തിനും autoimmune, sir.
Okay, I'll tell you. Yeah, but
No.
Autoimmune workup.
no, let's see.
Even if the potassium is normal, it can be periodic paralysis.
Yeah, it will be normal.
No.
Is it the presentation periodic paralysis?
No, sir. It will be more abrupt.
Episodic. And then
It will not last for such a.
Second, on prolonged walking, the character changes. I'll tell you what I thought. See, the behavior, when somebody has got abnormal movement of the body, or the limb goes into haywire, but normal power. One, you have to think of a bone lesion. Okay. Also, you have to think that there is an abnormal contraction of the muscles. Okay. It's abnormal contraction could be dystonia. Okay, when your task is done, when one muscle is contracting or overcontracting, that goes into abnormal posturing. And incidentally, this particular gait is called the dromedary gait, characteristically described in DIT1 gene. I'm not telling this one. In dystonia muscular deformity, this is the type of abnormal gait they get. The thigh get adducted to the contralateral leg, and the thigh get flexed. Hip get flexed, sagged. So this kind of a gait is also described. So more likely this is a kind of a dystonia in this patient. Now, how to prove the dystonia? See, we have excluded weakness, we have excluded neuromuscular problems, we have excluded central nervous system problem. but you have to prove it. So let's say
EMG.
Levodopa challenge?
no, and before that, we have to prove, but it improved with steroids all the time. That we can do, the order which I can do. But let's see what I did in this patient. See the distributed walking.
Okay.
Too much of a drag.
എന്താണ്
Asked him to walk backward.
നടന്നോ മുന്നോട്ട് എന്നിട്ട് ഇനി റിവേഴ്സ് നടക്കാം ബാക്കിലോട്ട് നടക്കാം
Walking backward is normal.
അത് മുമ്പോട്ട് പോകാൻ നേരെ മുമ്പോട്ട് പോകും അതിന് റിവേഴ്സ്
One group and walking forward may not be a person.
ഇനി റിവേഴ്സ് നടക്കാൻ
Not there on walking backward.
ശരി അവിടെ തിരിഞ്ഞ് അങ്ങോട്ട് തിരിഞ്ഞു തന്നാൽ ഇനി എൻ്റെ സൈഡിലോട്ട്
Walk backward.
ശരി മതി
I'll show another video also. See the way he's walking on the distance.
അന്നേരം പോയിട്ട് തിരിച്ചു പോകാനെ അങ്ങോട്ട് നടന്നു ബാക്ക് നടന്നു റിവേഴ്സ് ചെയ്യണം ഇനി മുമ്പോട്ട് വാ മുമ്പോട്ട് വന്നേ ഇനി റിവേഴ്സ് ഒന്നിട്ട് നടന്നേ റിവേഴ്സ് നടക്കുക
So he has got dystonia, but it's not a progressive dystonia like D1T abnormality. So look for the other features of external environment. You look at his tongue. You Getting in sense, it also you can find the core. How the upper lip. Okay, so what is this condition? He has got chorea now, he has got dystonia in the lower limb over a long period of time, recurring and remitting. This is called pediatric autoimmune neuropsychiatric disorders associated streptophagia. Our PANDAS, originally the so-called Cheltenham's chorea variant. Now, I'll tell you brief about this particular entity. Presence of obsessive compulsive neurosis or disorder and tics are the characteristic things which occur, which are severe enough to interfere with the ability to function. Symptoms appear between 3 years of age and puberty, although later onset of symptoms are also possible. Symptoms appear abruptly, dramatically, typically within 1 or 2 days in our patient, may repeatedly improve and then suddenly worsen, a relapsing remitting course. One part of the brain that is affected in PANDAS is the basal ganglia, which is believed to be responsible for the movement disorder and the behavior abnormality. It is thought that similar to Cheltenham's chorea, antibodies cross-react with the neuronal brain tissue in the basal ganglia to cause tics, OCD that are characteristic of the PANDAS. So these are the associated similar conditions described. Dystonic syndrome associated with anti-basal ganglia antibodies. In 5 adult patients, I think I forget about the clinical syndrome, dystonia, and anti-ABGA antibody. Then a possible variant of PANDAS, dystonic subtype. This is another case from literature. Then post-occipital dystonia with bilateral striatal enlargement. Although classical post-occipital neuropsychiatric disorder Cheltenham's chorea, Recently, other post-streptococcal basic ganglion subtype phenotypes have been described, in which patients not meet the criteria for syndrome scoria. One of the disorders is called the post-streptococcal dystonia. And these disorders are autoimmune mediated with antibodies attacking certain parts of the brain, specifically the basal ganglia. Okay, now the name has been changed from PANDAS to PANS because it was what do you call it? It may not all the time have neuropsychiatric problems. Yeah, sorry, it's called pediatric acute onset neuropsychiatric syndrome rather than PANDAS. Okay, any questions in this case?
How often do you find the anti-basal ganglia antibodies in these patients?
It is not done here. It's a dopamine receptor antibody. I do not know where it is done. I inquired about it. It's not done anywhere.
So was this episodic or it was progressive?
It is episodic. This time he came with last 1 month history. Prior to that, he improved. Then 5 months back, another episode, again lasting for 1 or 2 weeks.
Improved with the steroid.
Some of the improved spontaneously, some of them improved. That's really responsible, we don't know. Most likely so, because basically,
steroid was started with what diagnosis in mind, sir?
Pardon?
Previously, steroid was started with what was the diagnosis when steroid was given?
It was not started by me, it was started from elsewhere. They didn't have a diagnosis. They tried something.
കാടടക്കി വെടിവെച്ചതാണോ അല്ലെങ്കിൽ അവരെന്തെങ്കിലും കണ്ടിട്ട് കൊടുത്തതാണോ?
അല്ലല്ല, അത് നമുക്ക് അതിന് മുമ്പത്തെ എപ്പിസോഡ് ഇംപ്രൂവ്ഡ് സ്പോണ്ടേനിയസ്. We also like steroid and find out. So
in this case, basal ganglia was normal.
MRI was normal.
MRI was normal. The thing is that, see, first of all, you have to find out the semiology. What is the walking difficulty due to? Bone problem is a logical thinking. Muscle weakness is a logical thing with fatigability. It's a thinking. But they're all excluded. All these guys also recheck the power again and again. You must have seen me how I was doing the power. I checked the adductor twice because the abduction was going, limb was going to abduction. They are all normal power. See, it occurs only episodically. And you can also see the walking difficulty become much worse at different times and prolonged walking. When he was walking the second time over long distance, how clumsy it was. It was not there the first time when he walked. So that means there is periodicity there. That's all well known with dystonia.
Were there any diurnal variations, sir?
No diurnal variation as such. The clue, the other point favoring dystonia is walking normally backward. But so much clumsy forward, backward is okay. The same limb did not show an abnormal contraction. That is peculiarity of dystonia, a person who cannot walk and dance normally.
So is penicillin prophylaxis indicated in such patients?
In fact, that's a good question, because the problem is, and many people, we usually advocated for this condition, syndrome scoria. Nowadays, there are two schools of thought, whether it's required or not. There's little controversy, because I read about it. Little controversy whether to give this thing for the even PANDAS, because it's basically an autoimmune mediated disease. The infections triggered it, streptococcal infections triggered it, but it is not a persistent. The antibody is the one which is causing the culprit. So whether penicillin product required or not, there is a controversy.
Do we need to consider any channel involvement and metabolic causes since it's episodic, like ATP1A3, GLUT1?
The GLUT1
energy deficiency effects.
It's unlikely, because the CSF sugar was normal, on the higher side. That I considered. The other things we have to do genetic testing. But the problem is it is solved in, as you said, in the other condition also can be episodic. That possibility cannot be rolled out totally. But here, the movement disorder is different. You have a chorea, he has also got a dystonia, in different parts. I thought most likely this is the condition. And improving spontaneously.
Sir, how long steroid was given for this patient?
Previously, I don't know how long did they give, maybe a short period. This time we give for a short period only.
Sir, is that the drooping of the shoulder also could be due to this?
Not now. It was reported earlier. The doctor detected earlier. Not the doctor. The history was there is a drooping earlier. Okay. Shall I go to the next case?
Yes, sir.
Okay. This is an 18-year-old presented ptosis since childhood. Look at this is an interesting ocular movement I wanted to see, not the ptosis part.
ओपन करो, ओपन करो, ठीक है, ऊपर देखो, ऊपर देखो, ऊपर देखो, okay.
Look at the ocular movement.
मैंने
But okay, normal. It was normal.
नीचे देखना, ऊपर, okay, इधर.
Looking to the right side. Now looking to the left side. The right side.
इधर इधर देख, इधर.
Action movement.
ऊपर.
Normal.
इधर, 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 ऊपर, इधर. जोर से बंद करो, जोर से छोड़ दो. ओके, इधर देखो, देखते रहना, देखते रहना.
Okay, I think I'll show the ocular movement part once again.
ओपन करो. ओके, मैंने अंगुली को देखना, नीचे देखना, ऊपर. ओके, इधर.
To the right side. Down. Left side, right side. Right side.
इधर इधर देख, इधर, ऊपर, इधर, 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 ऊपर, इधर. जोर से बंद करो, जोर से छोड़ दो. ओके.
Down and to the right. Down and to the left side. Okay.
इधर इधर देख.
Any thoughts?
इधर. ओपन करो.
Left inferior rectus weakness.
But the duction movement is normal. I'll show the duction movement once again. Your closing eye movement is
इधर,
normal.
इधर, ऊपर, इधर. जोर से बंद करो, जोर से छोड़ दो. ओके, इधर देखो, देखते रहना, देखते रहना.
But it is the
Right inferior oblique.
if it is super, the eye should, no,
Right inferior oblique.
with right inferior oblique or looking to the left, right eye should go up. It is simply going down. I will show once again. I should have
ओपन करो, ओपन करो. ठीक, नीचे देख, ऊपर.
See this one. On looking to the left side, the right eye goes down. Had been a right superior oblique palsy, I should not occur. I should have been right, I should have been. Could be inferior rectus weakness of the problem. This is either other side also. And in the infrared it could have been affected normal here. Also the other side now, this side. See that looking to the right side also, left eye is going down. It appears like a right inferior rectus weakness. So in that case, you have to think bilateral inferior rectus weakness. But closing one eye, the right eye can be fully brought it down in the abducted position. And again, I will show that in the closed position. See this one. That can be brought down.
What about superior movement of right eye on adduction?
That's also I've shown you. It's a part.
नीचे देखना, नीचे देखना.
This one.
So down gaze part.
Okay.
अंगुली को देखना.
Upward movement is slightly restricted on the right side. Downward movement is normal.
On adduction, sir, on adduction.
I'll come
right
to that.
eye adduction.
Yeah, right eye adduction. I'll come to that. Looking up. Where was that? There, let me see once again.
ऊपर देखो, ऊपर देखो. ओके. मैंने अंगुली को देखना, नीचे देखना, ऊपर. इधर.
Now I'm looking at the right side. Sorry, wait. The elevation was that particular picture I wanted. I should have looking first there. I don't know how it is.
So depression of the both eyes are affected.
Pardon?
Depression of both eyes are affected.
Then mean bilateral inferior rectus palsy.
Yes, sir.
Yeah, that's a possibility, but duction movement is normal. See, when you look with version movement, there is apparent restriction as you detected. But when you close one eye and then you ask the patient look down in the abducted position, it is moving normally.
The patient has this problem since.
Pardon?
It's a recent one or since childhood it is there, sir?
Must have been since childhood because
Non-paralytic squint.
So it is weakness to squint, sir.
Yeah,
Overactivity of the muscle rather than paralysis.
Right. So this is a well-known entity called bilateral superior oblique overaction. I'll tell you what it is. I'll show another child. This is akin to the similar one, but this I have shown you earlier. The 6-year-old had fever 2 weeks back and found an upper respiratory infection. He did not go to school for 1 week. When he went back to the school, he was noticed to turn his head to one side whenever he was reading or watching TV. That's a story, but this problem is also present from birth. Forget about the history. But it's only one eye.
പറഞ്ഞപോലെ ചെയ്താൽ അച്ഛൻ മുട്ടായി വാങ്ങിച്ചേരെ കേട്ടോ.
Right eye goes down. But here the upward movement is restricted, unlike our patient. Our patient looking up, it is moving up. It is not moving up. See this moving, not moving up on the right side. Okay. On left side, right goes. Depression. This is the DD of superior. But here there is restriction of elevation also. Wait, now see it's cannot elevate on the adducted position. Also cannot elevate on the right. What is this condition?
Brown syndrome.
This is the Brown syndrome. Yeah. This is because of superior oblique tendon shift syndrome. Superior oblique tendon tendinitis, so tethering prevents the elevation of the right eye in the adducted position. It looks like an inferior oblique palsy on the right side. Correct? Because the adducted position, the eye goes down. That is because the prevention by the tethering by the superior oblique tendon sheath. That is why the patient is not able to look up also the adducted position. Unlike our patient, the patient is able to look up. The normal position also, if this patient look at the child is not able to look up even in the primary position. You're looking up, child cannot look up on the right side. So this is the DD, and this is called Brown syndrome. The diagnosis, the first case is by superior oblique overaction. Second is the Brown syndrome. I think I will skip this part, differentiate Brown syndrome from inferior oblique. I'll go to the chart by which we differentiate. Now, these are the three conditions which you have to keep in mind. Sorry. One is the first one is bilateral superior oblique overaction. Sorry, let me see this.
Chart, okay.
A chart and the first one is what?
Chart is blurred.
Upper black spot is blocked.
Brown syndrome. Okay. Wait. Okay. The first one is the Brown syndrome. Second is superior oblique overaction. The last one is inferior oblique paralysis. All will mimic the same. In the adducted position, the eye will come down. But these are the differentiating points. Limitation of elevation, the adduction is very severe in Brown syndrome, and usually mild in superior oblique overaction. Inferior oblique paralysis also it will be severe. But here it's able to look up, that means it's most likely to be an overaction. Then other things I think you can, bilateral involvement is most common with bilateral superior oblique overaction. Very unusual with other two conditions, inferior oblique paralysis and Brown syndrome. There are other small points, vertical deviation, and so many other things, pattern, EV pattern, V pattern. That else I not spend time on that. So these are the differentiating points. This is another video which I showed last time. This on the YouTube. So that's a story. Any questions on that?
So what is the main differentiating feature between Brown's syndrome and inferior oblique palsy?
Yeah, that differentiating point is that it behaves almost exactly the same. One point to remember is the primary position, there is no elevation or, elevation in the case of a Brown syndrome, but there will be elevation in the case of inferior oblique palsy because of the overaction of the other muscle. But since it is a tethering, the primary position, the eyes are normal in Brown syndrome. The other thing will not be elevated. So that is one point. Second point is that the torsional movement is affected in inferior oblique, but when inferior oblique palsy, but not in the tendency syndrome. What happened then is it prevents the movement of the other muscle. So it will not be an overaction of the other muscle will not occur. The torsional movement will not be there. The other point is the eyes on looking up and down. What is called the V pattern, the other is called the A. I will adduct up, the other is divert, the other will divert. That's why I can show the points. In Brown syndrome, no vertical deviation in the primary position. This is your question, answering to the question. If at all it's present, it is mild. Inferior palsy, vertical deviation in the primary position is there. It's large, and it's more than 10. In a case, none or V pattern is seen in Down syndrome. The eyes goes into divergence and looking up. A pattern with convergence upwards is in the inferior palsy. I think will not be positive in Down syndrome, whereas it will be positive. The Minkowski's rotation test, by which you differentiate. It's also given explanation for an A pattern. I think in the interest of time I will skip that. Okay, any other questions? Okay, shall I go to the next case?
Yes, sir.
No, it is important to say unless you find these things, you can easily dismiss the patient as congenital because his other evidence of you can always got. So whenever congenital shows other congenital abnormalities of. Now, this is a story of a 65-year-old male. I think just 1 minute. Do I have time for it or not? I know it remains there. This is a very interesting long case. Progressive dysarthria and dysphagia for 2 years. Tonsils in the left hand for 1 year. Slowness in walking for the last 6 months. This is the story. Progressive dysarthria and dysphagia for 2 years. Tonsils of the left hand for 1 year. Slowness in walking for the last 6 months. For examination, he was inattentive, pathetic, emotional ability. But actually, it is not apathy, it looks apathy. Impaired recent episodic memory and did not attempt for testing other higher memory functions because of his severe apathy or lack of initiative. Now look at this video of the patient. It's a long video.
இந்த பக்கம் பாருங்க.
Look at the
வலது பக்கம்.
Look at the.
ஏன் வரல பாருங்க. இந்த பக்கம். அங்க பாருங்க. இடது பக்கம் பாருங்க.
Look to the left side.
அந்த பக்கம் பாருங்க.
The right side.
இடது பக்கம்.
Looking down.
கீழே பாருங்க. கீழே கீழே.
You have to ask
கீழே பாருங்க.
times to bring side.
கீழே பாருங்க.
And again.
மோல்ல பாருங்க.
Okay.
மோல்ல பாருங்க. கீழே கீழே கால்ல பாருங்க. அப்படித்தான். உன்னோட பாருங்க. உன்னோட பாருங்க. உன்னோட பாருங்க. நீ மோல்ல பாருங்க. மோல்ல. இந்த பக்கம் பாருங்க. வலது பக்கம். இடது பக்கம். இடது பக்கம். பாருங்க இடது பக்கம் பாருங்க. உன்ன பாருங்க. ட்ரை பண்ணுங்க. இந்த வலது பக்கம் பாருங்க. கீழே பாருங்க. உன்னோட கீழே பாருங்க. அப்படி மோல்ல அடையுங்க. கண்ணு முறுக்கி அடையுங்க. முறுக்கி அடையுங்க. சரி போதும். கண்ணு துறையுங்க. என் விரலே பாருங்க. இந்த விரல தெரியுதா? அங்கே பார்க்கணும். கண்ணுக்கு அசைக்க கூடாது. அங்கேயே பார்த்துட்டு இருக்கணும். விரலே பார்க்கணும்.
Not able to focus on me. I'm not doing here.
என்ன பார்க்காதீங்க. இந்த விரல பாருங்க. சத்தமா சொல்லுங்க. உன்னோட சொல்லுங்க.
Say 1, 2, 3.
ட்ரை பண்ணுங்க. 1, 2, 3 அப்படி சொல்லுங்க. பாத்துறீங்க. பாத்துறீங்க. பாத்துறீங்க பாப்போம்.
The opening is
பாத்துறீங்க. அப்படித்தான். உன்னோட துறைங்க. ட்ரை பண்ணுங்க. சரி கண்ணு மூடுங்க. நல்லா முறுக்கி அடையுங்க. ஈ சொல்லுங்க. ஈன்னு சொல்லுங்க. ஈ அப்படி இல்லை. பல்லு முழுக்க காட்டணும். ஈ பாத்துறீங்க. பாத்துறீங்க. இங்க உன்னோட சொல்லுங்க. நாக்கு நீட்டுங்க. நாக்கு அந்த பக்கம் இந்த பக்கம் தள்ளுங்க. நான் இங்க பாருங்க. இப்படி நாக்கு நீட்டுங்க
கேட்டுங்க.
நீட்டுங்க
Put out the
ட்ரை
tongue.
பண்ணுங்க. இல்லை சொல்லிது கேட்கணும் விலம் கொடுக்கா நான் சொல்கிறேன். என் கை பிடிக்கக்கூடாதே, பிடிக்கக்கூடாதே, பிடிக்கக்கூடாதே. பாருங்க, என் கை பிடிக்கக்கூடாது, என் கை பிடிக்கக்கூடாது. விடுங்க 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 விடுங்க, கை விடுங்க.
Hand follows my hand. So I move the hand will follow.
என் கை பிடிக்கக்கூடாது, என் கை பிடிக்கக்கூடாது, என் கை பிடிக்கக்கூடாது, 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 பிடிக்கக்கூடாது. ஸ்பீடாக காட்டுங்க, நான் செய்த மாதிரி இப்படி செய்யுங்க. இந்த கை இப்படி ஆக்குங்க, இடது கை, மற்ற கைனால, மற்ற கைனால, மற்ற கைனால மூக்கில் தொடுங்க. எந்த கைனால மூக்கில் தொடுங்க, மூக்கில் தொடுங்க, உங்க மூக்கில் தொடுங்க. இது வந்து இப்படி தொடரணும், செய்யுங்க. மூக்கில் தொடுங்க, இது தொட்டுட்டு இங்கே அந்த மூக்கில் தொடணும், மறுபடியும் என் பேரில் தொடணும், இப்படி செய்யுங்க. சரி, நீ மற்ற கைனால இப்படி. அப்படியல்ல, இந்த ரெண்டு பேர்ல மட்டும் போக்குங்க. சரி, இப்படி காட்டுங்க, இந்த விக்ரி மாதிரி இப்படி காட்டுங்க. இப்படி இப்படி முறுக்கி பிடிங்க, முஷ்டி பெட்டி. அப்படித்தான், ரெண்டு பேர்ல, மற்ற பேர்ல வரக்கூடாது, பிடிக்கக்கூடாது, ரெண்டு பேர்ல. மற்ற கைனால இப்படி பிடிங்க, பாதம் முக்கி பிடிங்க. கத்தி முകളിல் வரட்டேன், முകളിலே வரட்டேன், இது முകളിல் வரட்டேன்.
All normal. Bandar is fixed.
கால் நீட்டி கெரிகிறப்ப தெரியுதா?
There is no micros in the signal. It's quite okay. But even though slightly short stepped and broad based. It is most profound in the. Okay, now what are the findings in this patient? I think let us analyze one part by one. That is easy for you. Let us first analyze this particular abnormality.
கீழே காலில் பாருங்க. அப்படித்தான், உன்னோட பாருங்க, உன்னோட பாருங்க, உன்னோட பாருங்க. நீ மோளில் பாருங்க, மோளில். இந்த பக்கம் பாருங்க, வலது பக்கம், இடது பக்கம், இடது பக்கம்.
What do you think about that abnormality? Anyone? Is it a slow saccade? It's not a slow saccade.
He's slow saccades plus the initiation of the saccade itself is.
Yeah, that's the problem. Saccade is not slow, in fact. In fact, the initiation is tremendously difficult. You have to hesitate for 1 minute to make a saccade. But the movement velocity is normal. That's the point you have to remember. I will show that one part once again just to clarify that issue.
கீழே காலில் பாருங்க. அப்படித்தான், உன்னோட பாருங்க, உன்னோட பாருங்க, உன்னோட பாருங்க.
Velocity. One may think that it is slow, but it's not slow. The velocity is normal. What do you call this kind of phenomenon? Where initiation is abnormal, the saccadic velocity is okay. This oculomotor apraxia. mild form of oculomotor. In extreme form, we will not be able to make any saccade, but initiation is severely affected. Now, initiation of oculomotor apraxia, saccade, and this why it is normal, because you can spontaneous saccades in mix in between is got a good velocity. And also one place you can also see apraxia of eyelid opening also. Let us see the next abnormality. Ask you to point my finger and make the move head slowly. Eyes goes along with the head. So what is abnormality? It's called vestibulo-ocular reflex is defective. It shows that pursuit system is abnormal. We do VOR by testing the head thrust test to avoid avoid your pursuit system. But here the pursuit system itself is defective. That is why the slow movement becomes abnormal by asking the patient to point to the object. This is called the visually evoked vestibulo-ocular reflex, showing defective pursuit system. Then what about think about his speech? Probably in Malayalam, what I can imitate what he's telling. He said, say 1, 2, 3, 4 like that. 1, 2, 3. It wanes off in volume after 3, 1, 2, 3, then stops. Well, once again.
சத்தமா சொல்லுங்க உன்னோட சொல்லுங்க 1 2 3 ட்ரை பண்ணுங்க
1 2
1 2 3 அப்படி சொல்லுங்க
Okay, what is this abnormality?
Hypophonia.
Hypophonia, you are right there. But what more important is that 1 2 3 it comes down. Just like your kinesia of your hand movement, it progressively diminishes in amplitude and stops. Similarly, in speech also, progressively decreases in amplitude, the amplitude of the volume or the volume of the speech, and then stops. So this is something similar to what movement akinesia, that's called the akinesia speech. But speech withers gradually decreases and stops. As gross hypophonia, moreover, sound wanes after 2-3 words and stops just like the akinesia finger movements. So speech akinesia. So let us see what is seen in this video.
This is apraxia rather than weakness. மாதறீங்க அப்படிதான் ஒன்னோட தரீங்க ட்ரை பண்ணுங்க சரி கண்ணு மூடுங்க நல்லா முறுக்கி அடையுங்க ஈ சொல்லுங்க ஈன்னு சொல்லுங்க ஈ அப்படி இல்லை பல்லு முழுக்க காட்டணும் ஈ பாதறீங்க இன்னொன்னோட சொல்லுங்க நாக்கு நீட்டுங்க நாக்கு அந்த பக்கம் இந்த பக்கம் தள்ளுங்க நான் பாருங்க இப்படி
But it can follow normally.
நீட்டுங்க
What is that abnormality? Bindu, anyone?
Sir, he is opening on asking he is opening the mouth, but on asking to protrude the tongue, he is not. So, on command, he is not doing that act.
Correct.
So it is.
It's an no. It's an
orolingual
orofacial apraxia. Now, why I am telling you? Sometimes he's open, sometimes he's protrude the tongue because that is a spontaneous act. So he's got command in his mind, but on command he will not do that. Sometimes it so happens that the spontaneous movement come in between, he'll open it that. So that's why the automatic voluntary dissociation is characteristic of apraxia, where the patient would voluntarily asking the patient to do, he cannot do, but sometimes spontaneously, automatically, he put out the tongue or open the mouth, he closes the eyes. Ask him to close, he will not. That thing is what is said in apraxia. This is an orofacial.
This is apraxia.
Now, what does this video show? I think you see, you cannot imitate.
இந்த ரெண்டு விரல மட்டும்
Not communicating.
சரி இப்படி காட்டுங்க, இந்த விக்ரி மாதிரி இப்படி
or
காட்டுங்க,
communicating distance as well.
இப்படி இப்படி முறுக்கி பிடிங்க, முஷ்டி பிடி. அப்படித்தான். ரெண்டு பேரில் மற்ற விரல வரக்கூடாது, பிடிக்கக்கூடாது.
What
ரெண்டு
is that?
விரல எந்த கையினாலும் இப்படி பிடிங்க.
That is intransitive ideomotor apraxia. Now, what does this video show?
பிடிக்கக்கூடாது, என் கை பிடிக்கக்கூடாது. விடுங்க 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 விடுங்க, கை விடுங்க. Grouping.
That is called the grouping phenomenon. That is called magnetic apraxia. It's like a magnet, it follows your hand. It is an elder brother of grasp reflex. So the cardinal findings are impaired attention, memory, ideomotor, orificial apraxia, oculomotor apraxia, prominent grasp, bilateral rigidity more on the left side. Rest of things normal. So what is the likely diagnosis?
Corticobasal syndromes.
Yeah, corticobasal syndrome. So important negative findings are saccades are normal. There's no cortical sensory loss. So cytopathology, oculomotor apraxia suggests bilateral dorsal stream involvement in the perioccipital cortex. Severe rigidity akinesia basal ganglia, grasp and grouping prefrontal cortex. So sensitive of a basal corticobasal syndrome. It did not involve all the features of cortical basal CB ganglionic disease.
The left hand, is there a dystonia, sir? Slight dystonia, posterior.
Dystonia, in fact, maybe there I did not clearly look for that. I was more interested in the other higher manifest abnormality and the rigidity. Obviously, it's severe rigidity on the left side. There's also dystonia. I think there's dystonia also.
Sir, one doubt in CBGD, this saccades initiation is so affected, sir?
Well, that can be affected. In the late stage of CBGD, just like a Parkinsonism, they got a slow gait. Say Parkinsonian syndrome. Let's stop, then show the video, the MRI of the patient. It's got bilateral hemispherical atrophy more on one side. And ventricular dilatation. It also has got a penguin sign, but even the penguin sign is there, the midbrain pontine ratio is normal. So the penguin sign is not pathognomonic of PSP. It can occur in many other conditions. What is more important is the midbrain pons ratio. That is more important diagnosis PSP. So I'll stop here because I got another lecture at we have to start the another session. Any doubts?
How was the response in Syndopa at this patient?
No, he did not respond at all.
Okay.
Unrelated doubt.
Pardon?
Unrelated to this case. Doubt, simple doubt. Why only for bicep jerk we are putting a finger in between? All other jerk we are directly hitting the tendon. What is the difference?
It's only whenever you can. Is there any position where you can stretch the tendon? That is enough. You don't put the finger. We also put the finger in the case suprapatellar reflex, because the other you can directly strike the tendon or the bone in it which is attached. Purpose is to stretch the muscle tendon. So in the case of biceps, you strike on.
We put directly bicep tendon. What is the answer?
You can also do like that, but it will be more effective when you put the finger. Just like the suprapatellar reflex, you put that finger onto the tendon rather than striking on that. That's the effective stretch on the tendon.
Our finger will be painful after doing this bicep tendon for all the patients.
Okay.
So, is there any harm in doing it without?
No harm in doing it, but sometimes you may not get. So I think I'll stop here because 10:30 I got that masterclass meeting. So see you next week. Thank you for listening. Okay.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you very much.
Thank you, sir.
Thank you. Thank you. Thank you very much.